You.
Sorry.
Oh, let's start it again. So welcome everyone, and we're gonna start with those objectives. So Jenny, if you can move the slides forward. We are going to review updates on HIV treatment and prevention, as well as criminalization. We will examine stigma and its impact, especially stigmatizing language and biases. We will discuss and practice inclusive and non-discriminatory language, behavior, and community outreach best practices. My name is Alejandro Acosta. I am the HIV Advocacy Project Coordinator for Equality Florida. I have been with the company for 2 years, and was an educator for 17 years prior to that.
Hi, and I'm Jenny Smith-Camejo. I am Communications Director for Positive Women's Network USA. We are a national membership organization of women living with HIV, and we do advocacy at the federal and state levels. And I have been with PWN for 4 years. And so we're going to get started with just some updates. I'm not sure of everyone who is on the audience or who might be watching the recording later. So apologies if any of this is stuff that you already know. I'm sure for folks who work in the HIV realm or who do a lot of extensive work with the HIV community or reporting on HIV issues, a lot of this is stuff that you will already know. But it's not necessarily common knowledge, unfortunately. So we want to make sure that anyone who's watching this in real time or later has all of the sort of latest facts about HIV as it stands in the US today. And so since this webinar is really intended, although I realize we have probably a pretty wide range of folks who are here, but the intended audience is really media. And so some of the stuff that we want to focus on is how media can get stories about HIV right. And I think one really, really important thing is, and this could also apply to non-media sources, whether, just anytime you're sort of working with people living with HIV or doing outreach in communities of people living with HIV, you can always share information. Education reduces discrimination. When people know about what an HIV diagnosis means today, when you really understand the science and the treatment and prevention options that are available today, it's a very different thing than it was back in the 80s or even the 90s. Things have changed a whole lot. So some of the facts, and this is a picture of a palm card that Positive Women's Network produced recently, and I will be sharing the PDF of this with you all over email after the webinar. That should be coming probably tomorrow, so keep an eye out for that. I highly encourage folks to print these, especially if you, if you work in an office or somewhere where HIV is something that is talked about. Also for media outlets, this is good information to have. So some facts: a person living with HIV who takes their antiretroviral medications as prescribed can reduce the amount of virus in their blood to an undetectable level. And what that means is you can live a normal, healthy life. And the next slide is going to go a little bit more into detail about that, and also about U equals U, which is the next bullet point on here. And then we touch quickly on criminalization. So there are 35 states that criminalize people living with HIV for consensual sexual activities. But criminalization has never been shown to be effective at preventing transmission. And in fact, it's often counterproductive to efforts to end the epidemic. And success at reducing new transmissions has been achieved by improving access to care and services that are needed to stay in care, things like housing, mental health, transportation, and by engaging people living with HIV in leadership roles in efforts to end the epidemic, and addressing the factors that make people vulnerable to HIV, like poverty, racism, transphobia, homophobia, and discrimination. So this is sort of an overview of some of the new information. So undetectable equals untransmittable. I'm sure folks who work in HIV or with people living with HIV are aware of this, but unfortunately not everyone in the general public is yet. So basically what this means, like I said on the last slide, a person who's living with HIV who's on effective treatment can reduce the amount of virus in their body to levels where it can't be detected in labs, and that's called an undetectable viral load. And a person with an undetectable viral load may say that they are undetectable. And a person with an undetectable viral load cannot transmit HIV to sexual partners, cannot, even without condoms. And this is really important to know, because it's not that it reduces it by a large part, or I mean, it's just not physically possible to transmit HIV when you have an undetectable viral load. There's just not enough virus in the body to actually transmit it. And so this is really important to know. It used to be that the guidelines said that you had to have an undetectable viral load for at least 6 months, but my understanding is recently that was revised, and when you have an undetectable viral load, you cannot transmit, period. So 6 months that's a great sign that, you know, that the person is adhering to their treatment, et cetera, but it's not necessary in order for HIV to be non-transmissible. And this is something that has been proven and confirmed by numerous large-scale studies over the past decade, including thousands of different couples. That means couples who where one partner is HIV positive and the other is HIV negative, but that are both heterosexual and same-sex couples, and hundreds of thousands of condomless sex acts. And so some of the most famous of these studies are HPTN 052. Those results came out in 2016, but the study was actually it started in 2005, and I think it went all the way up to probably 2015. It was about a decade. Partner, the results were announced in 2016, and then Partner 2, the results were announced last year. And you can learn more information about this at u=u.org. Did you have anything you want to add, Alejandro? Okay.
No, so fine.
Cool. And so another thing that I think is equally important to talk about is, if U=U, why is everybody who's living with HIV not undetectable? It's a good question, it's a fair question. It's really great news that U=U is just wonderful news in general, and it holds a whole lot of promise for efforts to end the epidemic, but there are still a lot of obstacles in the US that prevent a lot of people who are living with HIV from becoming undetectable. And it's important to kind of understand what those are and be sensitive to them in the context both of reporting about it and also when working with people living with HIV, understanding that there are a lot of barriers to reaching undetectable for a lot of people. And some of those, just a few of those, are unequal access to affordable health care. This is a big, big problem, especially in some of the communities that have been hit hardest by the HIV epidemic, in low-income communities and communities of color. Not having access to healthcare both before and after diagnosis is a huge barrier. Stigma and bias in medical provider settings. This is especially true for LGBT and trans people. If you go to a doctor and you're made to feel like less than human or like somebody that you're not, you're much less likely to continue going to the doctor. And if you're in a place where there are very limited options of where you can go to get treatment, this might mean that you end up falling out of care. This is a really big problem. Lack of supportive services that are needed to stay in care. That's things like housing, mental health care, transportation, which transportation can be a huge barrier in rural communities, especially if you're homeless, you know, going to doctor appointments and having somewhere to put your medication, let alone remembering to take it regularly. It's incredibly complicated. Mental health care, the rates of depression and PTSD among people living with HIV are extremely high. And when people don't have access to mental health care, that's also a huge barrier for staying engaged in care. Mass incarceration and disruptions in treatment, big problems in communities that face mass incarceration, like the Black community, Latino people. This is a big problem because if you get locked up, then, you know, if you were on treatment before, you don't always have access to treatment anymore. Maybe you get tested, maybe you don't, depending on the state and the locality. There's a lot of issues around that. And drug resistance. This happens more often in long-term survivors who've had a whole lot of different types of treatment over the years, but it can happen also with people who have had frequent disruptions in treatment. It doesn't mean that there's no way to reach undetectable, but it does make it more challenging to find a treatment regimen that works, because that can happen. Another thing that it's important to know about is PrEP. Pre-exposure prophylaxis, excuse me. And this is a really exciting tool. I think a lot of people have heard of this, but there may still be folks who haven't. This is an exciting tool that prevents an HIV negative person from acquiring HIV by taking 1 pill a day, and it is 99% effective. It's actually an HIV medication that, if taken by a person who is not already living with HIV, prevents HIV acquisition. Many insurance plans cover PrEP, and especially for people who are considered especially vulnerable to HIV and that can have low copays or no copays at all. But it is very expensive for people whose insurance plans don't cover it or who don't have insurance or who have high copays or deductibles. So unfortunately right now, the uptake of PrEP is still very unequal, like many other things in our society. It's been a lot more of the white gay man community has had access to PrEP than folks in other communities, in large part because of the way insurance covers it. And unfortunately, many doctors still don't know about PrEP or don't know enough. And some people in medical settings have biases, particularly against LGBT and trans people, and that can prevent them from recommending or prescribing PrEP to patients who could benefit from it. So these are still some barriers to PrEP being more widely used.
I want to mention that PrEP is available through the Department of Health in some states like San Francisco, New York, Florida. So looking at your state's offering of PrEP through the health department could be a choice for those who don't have insurance.
Thank you. Yeah. Sorry. And just another update. This is as of this year, the US government has committed to ending the domestic HIV epidemic in a decade. This was announced in the President's State of the Union address back in February. The plan is called Ending the HIV Epidemic, a Plan for America. And this was announced in February 2019 and promised to reduce the rate of new HIV transmissions by 75% in 5 years and 90% in 10 years. And it will it'll direct resources into 48 target counties, Washington, D.C., San Juan, Puerto Rico, and 7 states that have a high rural HIV rate. The 4 pillars of this plan include expanding testing to diagnose people with HIV as early as possible, treating HIV early and rapidly to suppress the virus, since U equals U, as we discussed, scaling up prevention interventions such as PrEP and syringe exchange, and using surveillance data, specifically molecular HIV surveillance, which analyzes HIV genetic sequences to determine when an outbreak is happening and to target resources to address that outbreak. And the plan asks each jurisdiction to take the lead in creating and implementing an the epidemic plan that's tailored to the needs of their communities. There are some concerns around the Ending the Epidemic Plan, although it's generally really good news that the federal government is paying attention to HIV and that this is something that's being talked about and there's being some investment is being made in it. There are still some concerns. And so a few of these are that it's focused exclusively on biomedical interventions, which is pills and surveillance data, but it ignores many of the systemic and structural barriers to prevention and care. So pills are what works to suppress the virus, but you still have to get pills to people. And, you know, if you're dismantling the healthcare system and Medicaid and making it harder for people to access care, then it's going to be harder for people to get treatment as well. There's no clear plan for meaningful community involvement in local and the epidemic planning processes. And so if you don't have the buy-in of the community and the community is not, you know, going to help carry the message to where it needs to get, then that's going to certainly make it harder for it to work. The plan depends on molecular HIV surveillance, which poses a potential danger to people living with HIV due to stigma and criminalization. So by tracking people's genetic sequences, you know, they say that this is not going to be used for the purposes of criminalization, but there's really no way to guarantee that that won't happen since criminalization happens on the state level. So this is a concern. And the government is cutting funding from the agencies, it's cutting some funding that's currently being used to serve people living with HIV. So it's not necessarily being funded with new money. So this is a concern as well, because it could potentially disrupt some of the care and services that people living with HIV are getting. And there's some more information on this available on PWN's website at pwnusa.org, ETE-factsheet-2019. And I'm going to hand it over to Alejandro.
We are going to talk a little bit about HIV stigma and its impact specifically on the community of people living with HIV. We are going to start by just listing some of those, the most common effects of, you move the slide, most common effects of stigma on people living with HIV. So stigma actually deters people from being open about their HIV status. It is important that people actually know their HIV status for what we just mentioned about U equals U. Consider your place of work and the people that surround you. There are people in your close circles right now affected by HIV who might never reveal their status. This is a simple example of how stigma continues to keep people in the shadows. In order to end the epidemic, we need as many people as possible getting tested and treated. And against HIV stigma sometimes deters people from seeking those services. People living with HIV suffer from horrible isolation, social isolation, where they cannot express, their true selves or even just talk about it. It affects mental health issues like Jenny was mentioning prior. Depression, anxiety, stress, and substance abuse are all too common in the general population. Now add a stigmatizing disease like HIV to that mixture, and you can imagine that we suffer from a lot more than that. And I say we because I've been living with HIV for the last 17 years. HIV puts stress in personal relationships and interpersonal relationships, not only in those of romantic love, but also with family and friends, co-workers. HIV stigma affects healthcare decisions of the patients. Some people do not trust healthcare providers because a lot of them are attached to the government. So you might have people who have immigration status that have been unresolved, and so they might not want to go to a hospital because they know that their names are going to be then now owned by the government, and they don't know that connection between the Department of Health and, for example, ICE is something that we are aware that really maintains people away from making those healthcare decisions that will benefit them, including also some behaviors. A lot of people prevent going to the doctor, so they don't know, they might not get tested for STIs or HIV in years. And so people that also have HIV suffer internalized stigma because of the way that the society still reacts to HIV. A lot of times fed by media in sensational headlines. Next slide, please. So when we think about, again, HIV stigma and reporting, a lot of the reporting usually happens around criminalization, which of course Jenny already mentioned that 35 states and territories of the United States somehow have HIV specific related laws or a specific laws in their state. A lot of these news reports tend to disclose the HIV status of the person who's accused or the defendant. And so when we think about disclosure, usually when someone is accused of something, you don't get disclosure of their medical conditions as part of the reporting, except for HIV. So the disclosure of someone's status can literally put someone's livelihood in danger. They might lose their employment, they might lose their housing, they might lose friendships and family connections. The social ramifications of an undisclosed status can be huge. They have the potential of also putting someone up for violence from ex-partners, violence from people in their community, from people who might presume their guilt immediately without knowing the facts. So this again puts a strain on someone because their name is out there and now it's attached to a person living with HIV. A lot of reporting also perpetuates stereotypes, which in turn feeds misinformation about HIV. I can give you an example. We hear a lot about police officers being spat on or being bitten. And although these actions, although they're not attractive, right, they don't transmit HIV. A lot of reporting happens around acts that really don't have the risk that the reporting transmits. It also increases discrimination against people living with HIV, putting them again in the shadows and continuing to feed the stigma. When we also report about people not disclosing their HIV status, we feed on the myth that the responsibility falls only on one of the partners, where in fact the responsibility should still lie on both partners to bring this conversation up, not only about HIV, but about STIs and any other concerns. As we all know, sex also doesn't happen on schedule, as sex usually happens spontaneously. And so these conversations sometimes don't happen. So intent, it's not necessarily, there might not be an intent to harm, especially if there's substance involved or someone's partying and there's not really that conversation. The whole responsibility should not be put on only one of the partners living with HIV. I'll give you an example. Just last week, and we can see it the next slide, we had a huge headline, actually 10 days ago, right? And here we have the CNN headline, "Scientists discover first new HIV strain in nearly 2 decades." You have no idea how many people I had calling me, texting me, asking me questions about this, because unfortunately, most people only read the headlines, right? We live in a world where everybody has 5-second attention spans. And so they read this and they're thinking, oh my God, we really are now in danger. Next slide. So when we read actually in the reporting, this is like 4 or 5 paragraphs into the news, we actually find out that there's no reason to panic, that actually not a lot of people have ever been infected with this strain, and that it was actually discovered in 83 and 90, those 2 cases. A third case was discovered in 2001, and all these in very remote places in Africa. So it makes you wonder, and someone like me living with HIV, what is the value of this particular news, right? If it's not that it's misleading, a misleading headline, and it's a little sensational, maybe a little clickbait. Next slide. So when we're thinking about, and this happens when you are in your group meetings over the phone, or you're having a conference, or even if you have an office, you should talk openly about HIV. HIV, again, is not what it used to be in the 80s. So when we're thinking about change, we're thinking about everything could be changed. If you guys talk openly about HIV, you might have other people be more open about HIV. When we think about meaningful involvement of people living with HIV, is you might have people around you in your own circles that are living with HIV. They are the best resource for you to find out if they have any opinions, if you want to quote. It is important to have people living with their point of view, right? So of course, you might not be able to do this for every reporting, but it is something that you could do on your own time and find out, again, so that you report more thoughtfully about these news. Think about the context and how is this important for the community that you serve, for your audience. Is the information that you're providing scientifically accurate, right? If an officer got bit by someone living with HIV and now that person got arrested, that might have some value in terms of, well, it's news, right? Because it happened, but maybe we could then clarify that although biting does not transmit HIV, because that would be medically accurate, right? Making that note, that connection. Again, this might be an educational opportunity that you might have, including there at the end, that although this happened, there's nothing to worry about. That way you still report on the incident and use this as a learning opportunity for your audience. If you, again, have an office, or if you are everybody has a place to live, right? Find out and connect with your local HIV service providers. A lot of these organizations have great information of where to get tested. They usually also have events that you can maybe tag on to create a positive story. Stay informed about HIV, and again, sometimes highlighting a positive story instead of just the sensational ones brings a lot of hope for those people living with HIV. Again, visibility matters. Next slide. And so also language matters. And I think Jenny's going to take it up from here.
Sure. Although you should feel free to jump in anytime. So this is an image of the front of the palm card that I was referring to earlier. The other side has the facts about HIV, and this one is about language. Words have power. It's incredible. There's such a difference. And I just invite you to consider the difference between hearing an HIV infected person and a person living with HIV. just that one little phrase is it's a different impression, right? It changes everything. And these are changes that we can make that are simple to make. And they're little things that make a big difference. So we do need to talk about HIV, but we need to do it in a way that protects and respects the humanity and dignity of people who are living with HIV. And so any language that implies judgment or shame, that fuels stigma, and stigma is actually probably the single biggest driver of the epidemic today. So things to replace. Please, 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 please do not say HIV infected person, parent, etc. You can say a person living with HIV.
We also try to stay away from HIV positive, because by saying HIV positive, it places all, or HIV infected, it places all the focus on the disease instead of the person. So this is people language first, or people first.
Yeah. Absolutely, people first language. So as a general rule, you always want to try to put the person before the condition or the behavior, whatever it is that you're talking about. So same thing, an HIV or AIDS patient, just use a person living with HIV. In very specific contexts, it may be relevant to talk about patients who have been diagnosed with HIV, but people are not just patients. They are patients when they go into their doctor's office, but when they are living their lives, they're not just a patient all the time. So I would avoid using that unless you're referring to the very specific context of a person going to see their doctor.
Consider also the fact that we don't do this with any other disease, right? We don't identify people as the cancer patient or the diabetes patient or the disabled person. We usually tend to stay away from those. The same applies to HIV here.
Just avoid the word infect or infected in general. There are lots of different ways that you can say that without using a word that's stigmatizing, that brings to image, green pus and horrible things. You don't have to do that. You can talk about being diagnosed with HIV. You can talk about contracting HIV or acquiring HIV. You can talk about HIV being transmitted, transmissions instead of infections, cases of HIV instead of infections. There's a lot of different ways that you can say it that are not so stigmatizing. Saying died of AIDS, that's not even accurate. If one is to die of this condition, it's due to complications related to AIDS. So let's be medically accurate, like Alejandro said, and we talk about dying of AIDS-related complications. Unfortunately, this still happens in the US today. Not nearly as often as it used to, but it does, and we need to make that stop. There is no such a thing as full-blown AIDS. Repeat, there is no such a thing as full-blown AIDS. This is not a medical condition. It's nothing. You can say AIDS or you can say stage 3 HIV. There is not consensus in the community. Some people want to continue to use the term AIDS. Some people do not like to use the term AIDS and prefer saying HIV and stage 3 HIV. This has not been decided one way or the other, but there is definitely no such a thing as full-blown AIDS. That much there's consensus about. And then risky or unprotected sex is something that we hear a lot. I would encourage folks to be more specific. So for example, condomless sex, instead of saying unprotected sex, there are different ways of protecting oneself and protecting against what? Are we protecting against pregnancy? Are we protecting against HIV? Are we protecting against other sexually transmitted infections? So just be specific. If we're talking about condomless sex, just say condomless sex. And other stigmatizing language to avoid that's not directly related to HIV, but sometimes comes up in the context of HIV. Sex work or sex workers rather than prostitution and prostitutes, please. A person who injects drugs rather than a drug addict. And as we already said, as a general rule, it's better to always put the person before the condition or the behavior, because people are more than their health conditions and they are more than one behavior. Would you like to add anything, Alejandro?
No, that's fine.
Okay.
So we are going to discuss a little bit about HIV criminalization, which is again one of the topics that is mostly covered in media. 35 states, as we said before, or territories criminalize HIV. One of the problems that these laws have is that they have not been updated, a lot of them since the 80s when they were implemented, meaning that they ignore all advances on science of HIV prevention and treatment. Some laws, like the laws here in Florida, also even ignore condom use as prevention. So that's problematic. So when these laws are still being implemented all across the United States, and they have a disproportionate punishment. Again, no other disease is criminalized the way HIV is. Right now, the disease is criminalized in a lot of states as a felony, with up to 30 years of incarceration in a lot of cases. When we're talking about 30 years of incarceration for possible transmission or non-disclosure, this doesn't mean that actual transmission occurred or that there was actually intent to harm. And just consider that, for example, someone who does who kills somebody on involuntary manslaughter, a lot of times has like a maximum sentence of 15 years. The burden of proof lies on the person living with HIV to prove that they disclosed or that the partners knew about it. As you guys know, disclosure of any type of condition, especially during sex, happens in private. And so there's no real evidence of that disclosure. And so you have a lot of cases that have been based on revenge cases of where a partner might be mad at another partner and then they get accused. And of course, the police continues to act on them. A lot of cases, the police actually also not only publicize the name, but ask other victims to come forward. And when I say victims, I might use quotes because a lot of times this is a victimless crime, right? No one might have been infected or contracted HIV. And some of these cases continue to even to conviction, regardless of anyone's transmission. These laws are used inconsistently throughout the United States, differently in the state, and even sometimes differently by even the area of the state. It's used usually as a prosecutor's choice, and it depends on what type of prosecutor you have. If it's someone who's very conservative, they might be finding more of these cases and prosecuting them more frequently. Of course, these crimes target vulnerable populations, not only people living with HIV, but the Black community, sex workers, people who inject drugs, homelessness. So these are the people that usually get in touch with these laws. These laws, unlike some others, they do not require an intent to harm. A lot of them, again, it depends on what state you're in. In Florida, you don't have to have intent to harm anybody or even transmit HIV to anybody to be accused and convicted. And again, like restating the last point there, some states do not require transmission for arrest and conviction to occur. And I can give you an example for the next slide. We have these laws in Florida since 1986. The Williams Institute reported last year doing a research with our criminal system. And what they found is that, as I just told you, these laws are implemented very disproportionately throughout the state. In our case, only 10% of the people living with HIV in the state live in the county of Duval, which you see at the top right. But we find the most incidents and cases of people being prosecuted and convicted there because it's a very conservative, it's a very different place than South Florida, for example, where we have the most cases, both in Broward and Miami-Dade, but not as many cases or incidents of arrest or conviction. That's just an example. Most states vary. These studies have been done in California, Georgia, and Florida as of now. Next slide. Go ahead.
Sorry, I was muted. HIV criminalization in the media. So Alejandro gave you a rundown of HIV criminalization as it stands today, as it's enforced in some different places. The way the media treats HIV criminalization cases in general tends to be very problematic and contribute to stigma. So media coverage of arrests and prosecutions of people living with HIV usually tend to increase stigma and misinformation, especially when they're sensationalized or when the stories do not include accurate, relevant information about HIV and actual risks of transmission. We already discussed U equals U. Even when a person has a detectable viral load, people tend to assume that that means that like anyone that they have sex with without a condom is automatically going to contract HIV. It doesn't really work that way. Actual transmission risks are pretty low even with people who have a detectable viral load. And so being sure to give accurate information about that is really important. These stories, along with criminalization itself, actually discourage testing. Like say, take the test and risk arrest. And it can make disclosure even harder than it already is, because it does this thing where the person, a random person who doesn't know much about HIV, doesn't know a lot of people living with HIV, or doesn't know that they are living with HIV. In their minds, they can equate an HIV diagnosis with criminal sexual conduct or with dishonesty. And so it's really important, to try to avoid that, because these are things that make people less likely to talk about HIV in general, less likely to be tested, less likely to seek treatment or to stay in care. And often stories in the media bring up the HIV status of a perpetrator of actual sex crimes in ways that are sensationalized and often not even relevant to the story. I have read many stories about people who are, being accused of legitimately horrible sex crimes, and their HIV status is brought up even though there are no HIV related charges involved. A lot of times that's even in the headline. While I would just encourage journalists, even if it's not out of any sense of pity for or sympathy for the alleged perpetrator, to consider the many people living with HIV who are not engaging in any kind of criminal conduct. And just to remember that putting that kind of information into headlines and into stories is really feeding stigma, and it makes it sound like this is what people living with HIV do. And it's not. It's just not true. So I would say it's particularly in cases where there are not even HIV related charges, ask, is it relevant? Do I need to include this information? Because in many cases it's not. And so if you must report on criminal cases involving people living with HIV, the preference would be just not even to do it in the first place in most cases. But if it absolutely has to, because the editor says so, here are some good guidelines that I would really strongly encourage journalists to follow. So number one is, like I just was talking about, is the HIV status relevant to the story? If the charges don't include anything related to HIV, then really just leave it out of the story. Why even include it? When the case involves charges of non-disclosure, we're not talking about rape, we're not talking about molesting children, etc. When we're just talking about consensual sex between adults, avoid talking about victims. Is it clear whether transmission occurred or has been proven? If it's not, include that caveat in the article. Most articles don't even say anything about whether there was actually HIV transmission. In some cases, it turns out that, I would say probably in most cases, it turns out that the alleged victim did not even acquire HIV. And so we're talking about somebody being sent to jail sometimes for years for a case where nothing actually even happened, where there's no harm that occurred to anybody. So it is relevant to the story. And it's important to know that in most states that do enforce HIV criminalization laws, or that criminalize HIV under other laws, because that also happens, that usually transmission is not even required for prosecutions. So people can go to jail for consensual sex where nobody contracted HIV. I think that's a really important caveat to include in stories that are talking about these cases. And take the opportunity to include a little bit of education about the current state of HIV prevention and treatment. That can just be a couple of lines that mention U equals U, that talk about different prevention options. I feel like there are so many wasted opportunities where, there's always an opportunity to add a little bit of education. And continuing that, treating disclosure as the complicated matter that it is really important. Alejandro already touched on this, but disclosing one's HIV status to partners and potential partners can be really, really difficult due to stigma and misinformation. And if you know that you will not transmit HIV because you have an undetectable viral load or because you always use condoms, it might just feel like something that's even too much to take on, especially if you're not planning on being in a long-term relationship with that person. And then, as Alejandro mentioned, in some cases, it can even lead to violence. There have been several cases where women were murdered by sex partners after their status was disclosed. People who are in relationships with intimate partner violence, like this, the disclosure could be really dangerous. And because of criminalization, it also puts people at risk for being exploited and coerced and threatened to be put in jail. We know of a lot of cases where women in particular have been threatened by their partners. They were trying to leave relationships that involved intimate partner violence, and their partners threatened to have them arrested by saying that they had not told them their HIV status. So it's really important to just be sensitive to the fact that it's not as easy to disclose as people often seem to assume that it is. There are a lot of reasons why someone might not disclose, and it doesn't mean that they're, trying to perpetrate harm against anybody. And again, avoid treating people as victims and perpetrators in cases that involve consensual sex between adults, even if there's disagreements later. And avoid sensational headlines, please, and always use people first language. And PWN has some more resources that are available at the link down here at the bottom of the page. I will be sending that out as well after the webinar. So it will be in the follow-up email, so be sure to read that email. And we can open it up now to Q&A. If anyone has questions or comments, you can put them in the Q&A box. You could also put them in the chat box. Either way is fine at this point. Does anyone have any questions or comments? Or is there anything that you would like to add, Alejandro?
I just want to, again, add that overall, just to close as the last thought, you media and reporters, journalists have a huge responsibility because you guys get to frame public perception, and this is just a way of being just more mindful of the impact that you guys have as well. So when we think about HIV criminalization, when we think about HIV stigma, when we think about HIV overall, yes, advocates and educators and health professionals have a responsibility, but in this case, we're also hoping that you also recognize there's a responsibility on that reporting, and that the only way to end HIV by 2030 is to change the narrative and to change the way that we have covered HIV so far. That we need to make it a 21st century issue of what it is. It's just a manageable disease, and all this stigma that really is contributing to new transmissions could be and could start ending with the right framing. And so I, as a person living with HIV, want to thank anyone who participated today. And if there's any questions that we can answer, we're here, and we have a couple more minutes. We've
got a couple of questions here in the Q&A box. So the first one wanted to confirm that we'll be sending out the PDF card. Yes, absolutely. So my plan is to put together a little package for you all and for folks who registered but weren't able to make it. Where you will have the recording of this webinar, the slide deck, the website, the pages that were linked in the slide deck, as well as a PDF version of that preferred language card. And I strongly encourage folks to print that or have it printed, give it out, put it where it's available. Those are resources for you all to use.
Yeah, we'll also include the announcement on how to treat HIV criminalization from Amsterdam that came out in 2018 last year. It just is a memo from professionals from 20 international professionals in the medical field explaining how to treat HIV criminalization, just in general. So I think although it does is for law enforcement. It will have some great value for you. Do you want the other questions, Julie?
Yeah, so there's another question. Can you suggest alternatives to the term hotspots, which people will use to, where people use to target areas where quote unquote high risk populations gather? Any thoughts, Alejandro?
Well, whenever we say hotspots, we again think about kind of illness in a way. So we could say that there was an increase of transmissions in a geographical area. Again, just the term hotspot itself carries a negative connotation. So when you're reporting, try to be as neutral as possible. If there was an increase of transmission in a particular county, that could be said there, regardless of the people that live there or what risk they take, right? There was an increase of transmissions. I wouldn't call it a hotspot.
Thank you. Sorry, I'm trying to get a little more clarification on one of these questions.
And then
Okay, and then there's also UNAIDS have great language guidelines. Not sure when last updated, but excellent. I actually did not know that, and I'm going to look it up, and I will be happy to share that link as well, because we definitely want to be, helping to publicize any good resources that are out there around language or this topic in general. Let's see. And there was a question, can you recommend some sources other than PWN that the media can consult to fact check or get a quote? I'm looking for a little more information for what kind of fact checking, because I think it really depends on what kinds of facts you are checking. I know that in terms of like fact checking information about HIV, the CDC's website is actually very up to date now with information around U=U and PrEP and risks of transmission. If it's more about fact checking individual like cases or around criminalization, that's going to be a little bit trickier since those tend to be at the local and state levels. Alejandra, do you have any? I'm not sure exactly what kinds of things she wants to fact check. So I'm not.
Well, it's important to also know that if what you're looking for is like, for example, statistics or numbers, most health departments have websites that offer the numbers or the test results for each year. Of course, the CDC, the World Health Organization, is another great resource. And if you are trying to find out about HIV criminalization, HIV justice worldwide is a great resource for different materials and just for information overall.
Great, thank you. Are there any other questions? And Candace, if we didn't get what you had in mind, please feel free to put another question in the chat.
I also want to say to folks that in your packet of resources, you're going to receive a link for a demographic survey. If you guys could answer that as part of your follow-up, that would be great. And once again, I want to thank everybody who joined today for this webinar. You're on the right side of history right now. I like to say that this is the beginning of a change, a cultural change. And so thank you.
Yeah, thank you so much to everyone. Yes, and please do be on the lookout for the email. I am planning for that to probably go out tomorrow by Wednesday at the very latest. So keep an eye out for that. And thank you all for being here.
And share this with your colleagues.
Share the information, please. Let me see. Yeah. Thank you. Have a great day.